Good afternoon, everyone. First of all, I would like to thank Dr. Bansi Sabu sir for giving me this opportunity. And this is one of those uncommon things that we see. But talking about all those uncommon complications which we have discussed till now, this is another diabetes and lung complications. It is under-recognized, and the impact on the lung is surely there. I will try to summarize the epidemiology, path physiology, and clinical relevance of lung complication in diabetes. This is my history slide. This particular slide, it dedicates the 75 years of IDF and the 35,000-year journey of diabetes. As you can see, from honey urine to hybrid closed loop. The first test used to be the honey urine, and today we are in the era where we have significant CGMs and we have all those insulin pumps. It's a beautiful slide, and on the right side you can see all those great persons who have given their life for the improvement of people with the diabetes. Let's talk. This will be the objective of my talk, and I have no financial disclosures. I've used AI for my presentation to make it beautiful by using the data. Diabetes affects over 537 million people worldwide. And we are all familiar with the microvascular and macrovascular complications like diabetoretinopathy, neuropathy, we have CADs and everything. For the considering pneumopathy is also important. It's not been studied properly, and there are not many data available today. The pathophysiological rationale, the vascular damage which causes this thing, the immune dysfunction, and the metabolic effect. When the microvascular complication we talk about, as the lung is extensive tissue with a lot of microvasculature, as well as the collagen, connective tissue. When this lot of advanced glycation product is there, that causes this vascular damage as well as the immune dysfunction, along with the metabolic effects like insulin resistance and dysregulated adipokinatin production, may actively promote pulmonary fibrosis and chronic airway inflammation. These are some of the lung diseases associated with the diabetes, which we have infectious as well as non-infectious, like COPD, asthma, interstitial lung disease, pneumonia, tuberculosis, cystic fibrosis, lung cancer, obstructive sleep apnea. The basic mechanism through which the lung disease happens is the pulmonary function and the structural changes. When we talk about the functional decline, it's been observed in many studies that there is a decrease in FEV1, FVC, DLCO consistently reported in both the type 1 and type 2 patients across multiple meta-analysis and longitudinal studies. Restrictive pattern is one of the most prominent features seen in the diabetic patient. We need to be making sure that we do an X-rays. Most of the time the X-ray is not going to help you, so we can go for CT, and that can demonstrate some kind of subtle interstitial changes and measurably reduce lung compliance in diabetic patients. There was this small study from Iran, pulmonary function in type 2 diabetes mellitus, a case control study. It shows the lung function is impaired in diabetic and pre-diabetic individual compared with normal subjects in a sample of Iranian patients. There have been several studies, as I've already mentioned. The TLC is reduced, the lower DLCO, thickening of alveolar epithelial basal lamina, and the meta-analysis confirms this. The important thing which we miss in our clinical OPDs is that we sometimes ignore the patient complaint of shortness of breath. So we should make sure once a patient says shortness of breath, we should examine the patient. Being a diabetologist, I often see and I often feel that once you start listening to patient chest, you start listening to patient heart, you're not going to miss it. Once you find that there is no cardiovascular sign, you should always evaluate for the pulmonary function with the help of PFTs, X-rays, and if CT is required. Because giving them the correct diagnosis do make the difference in their quality of life. Now let's talk about the pulmonary infection. This is one of the major clinical concerns that need to be challenged. As we know, tuberculosis is so high in our country. I know most of us practice in private practices, and we don't see that many cases of tuberculosis on a day-to-day basis. But once you who are working in government hospitals or ones who have been doing their PGs, they know what tuberculosis burden means to this society. And with this diabetes and tuberculosis, this is something of big epidemic and epidemic in the country that need to be addressed. Diabetes significantly increases risk of active TB development and substantially worsens TB treatment outcomes. This is critical syndemic, particularly in India. Then there is bacterial pneumonia, streptococcal being the common one. COVID-19, as we have all been through COVID, so we know how the diabetic patients come to the life and the complications are more associated and the people lost their lives when they were diabetic. This is a particular paper, a review paper, which was, sorry, meta-analysis of Mendelian randomization about diabetes and tuberculosis. It did show that there was 2 to 4% increase in TB risk. There was no reverse causality. Sometimes what happened during tuberculosis, there is impaired hyperglycemia. But that doesn't mean that the patient is diabetic. The mechanism is diabetes impair immunity. There's higher TB susceptibility. The best thing you can do is public health screen TB in diabetics, integrate DM and TB care programs, prioritize good glycemic control. The limitations is like we need validation in higher burden regions. This is a very important slide as for me. I've worked in government hospital and as already mentioned, the burden of TB is so much and when it comes with diabetes, we have to be very careful. 15% of TB patients have diabetes. Hyperglycemia is again because of the impaired immunity, latent TB reactivation. There's more relapses and failure to mortality. And there's this activation of the latent TB in the cases of the diabetic patient. You have to be make sure that you screen such patients. The management part is another important thing. If the patient is got to be having the moderate or mild tuberculosis symptoms, then you can start with OADs like metformin and DDP4 inhibitors. But if the patient is going to be having severe symptoms, all the nerves, the autoneuropathy is taking place, the microvascular damage is taking place, which is resulting in and all the complication. Indian context. Need to make sure that we have enough data, we have this be done. This is my last slide. Diabetes silently damages the lungs, worsening infections, fibrosis, and decreasing pulmonary reserves. Thank you.